which I do enjoy. It's really, really rewarding and really great. So today I thought I would talk a little bit about the foot and how essentially age affects the feet. I'll go through a bunch of common ailments and things I see on a day-to-day basis, and a little about what causes them, a little bit about how to treat them as well. I'll talk about a few barriers to foot care that I've encountered in my time as a podiatrist as well. Things like, what prevents a person from actually seeking out care for their feet, whether that be for pain or for aesthetic reasons as well. I will talk a little bit about the role of podiatry and a little bit about what I do as well. And lastly, there will be Q&A at the end, and my manager Kamini, she will be here to answer any questions. But if you do have any questions that may not be answered today, I've asked her to send me those questions and I'll be able to answer them at another time. So lovely. A little bit about the foot. So you've got 26 bones in each foot. Altogether, that makes out in total a quarter of the bones in the body. And they do quite a lot. On average, you walk about 177,000 kilometers in a lifetime. And as you can imagine, if you're walking quite a bit, they are going to take your body weight and they're going to take a lot of punishment through that as well. They are also quite sensitive. You've got about 70,000 nerve endings in your feet, and they're responsible for things like balance and also, that feeling of if you're walking on uneven ground or if you've got a rock in your shoe. So they are very important for that as well. As you can imagine, if you are walking or running or doing things and standing all day, your feet will be stronger than your arms, and they're actually about 3 times stronger than your arms. So what about age? How does that affect the feet? Well, in terms of foot pain, that affects about 1 in 4 older people. We say older people as someone over the age of 60. And you can imagine if there is pain present, you're going to do everything you can to avoid it. And it can be due to a variety of reasons, things like injuries, so ankle sprains or broken toes. Occupation is a big one. So people who spend lots of time in their feet, people who use their feet for activities, running and those kinds of things. Disease is also a big one. Things like osteoarthritis, rheumatoid arthritis, bunions, diabetes. These can all affect the feet. And lastly, age. Unfortunately, as you do get older, your feet do go through a number of changes. Yeah. So what kind of factors affect the aging foot? So one of the big ones is what we call fat pad atrophy. So on the ball of your feet, if you were to touch there, you've got some soft padding right on what we call the metatarsal heads. And as you get older, with things like arthritis, as an example, that soft padding kind of will disintegrate and disappear over time. You can imagine if you've got bone there and you're walking on something quite hard, it will be painful. Your skin also goes through lots of changes as well. So you do lose skin elasticity. And it's important because the skin is elastic, so it means it can kind of bounce back from things like pressure. And we notice this through things like skin getting dry easier, skin ripping easier, and things like wrinkled skin as well. A number of bony changes also happen. So bunions are very common. Things like hammer toes, rheumatoid arthritis and osteoarthritis also affect the feet as well. Nail changes is a big one. As you do get older, things like thicker nails, fungal nails, these become more common as well. And lastly, changes to the shape of the feet. So feet can actually get smaller, or morphology due to diseases, can change the shape of the foot and create other problems as well. So I've put a quote here that I usually tell a lot of my clients, which is this: people tend not to worry about their feet until it begins to worry them. In my experience as a podiatrist, a lot of people, their feet is usually kind of the last thing they think about because they do tend to have a few more things that are more important to them. And I will touch on this a little bit later as well. Lovely. So here are some common foot problems that I'll go through. And we'll start off with corns and callus. So this is probably one of the most common things I've seen. Essentially, a callus is the body's defense mechanism. It's a hard layer of keratin that forms because there's pressure to a specific area. And when you have a little bit, it's okay because it actually acts as protection. So in my spare time, I do a bit of bouldering, a bit of rock climbing. So I've got calluses on my hands because I use my hands a lot on rough surfaces, and the callus there acts as a protective barrier so my skin doesn't rip. But you can imagine if it gets too thick or if there's too much, it can become quite painful. The difference between a callus and a corn is a corn has what we call a central nucleus. So it's a circular inverted cone shape with that point kind of digging straight into the skin. So you can imagine if you're walking and you put pressure on that, it's like having a pin driven straight into your foot. So as I said, one of the causes is excess pressure to the skin. And when you've got the callus and you've got repeat chronic pressure, that is what actually leads to this central nucleus, this corn forming. As you get older and your skin integrity decreases, you can't actually, your skin's not able to take the same amount of pressure that it used to in the past, and then corns and calluses become more likely. So one of the things I hear from my clients often is that, oh, I never used to get calluses or I never used to get corns. But because of, these changes in their feet, that is why they get it now. And lastly, bony deformities. So things like bunions or what we call prominent forefoot, where the ball of the foot kind of juts out and you get clawed digits. These create extra pressure areas around the feet, and if they're not taken care of, can actually lead to callus and corns. In terms of treatment, generally we use a scalpel to sharp debride. So we would kind of pare away the skin. If there is a corn, I would try to take out that central nucleus and basically just dig it out. Chemical debridement, so you can use things like salicylic acid as well, but it's not very common. Use of moisturizers and emollients just to keep the skin nice and soft and nice and moist will help to decrease the amount of callus or the frequency at which it comes back. Corn pads is a very common thing you can get over the counter from places like pharmacies, and I would advise caution with these, and I would not recommend the use of corn pads in anyone with who is immunocompromised or who has diabetes. Because essentially corn pads, they're medicated with salicylic acid, which is what we call a keratolytic. It basically just burns through skin, but it can't actually distinguish between good, healthy skin and the corn. So do be careful when using it. And lastly, we do want to address the underlying factors. So if the corn is due to the way they're walking, we will look at things like, getting orthotics or putting padding in shoes just to kind of take the pressure off or redistribute it so that they're not getting those corns and calluses anymore. So next up, we have warts. I put this straight after corns and calluses because they do present quite similarly. The technical name is verrucae pedis, which is plantar warts. They are quite painful. As you can see from this picture, they have this kind of cauliflower and kind of bumpy appearance with these little black dots, which is the vascularization, so the little capillaries kind of bursting in the blood. In terms of how to differentiate between the two, we do what's called a lateral squeeze test. So if you push directly onto the lesion and there's pressure and there's pain from that pressure, then it's usually a corn. But if you squeeze it from the right and left, what we call lateral squeeze, and there's pain, then it's more likely to be a wart. It is caused by the human papillomavirus, which is the same virus that causes other warts and cold sores as well. It spreads via skin-to-skin contact or contact with contaminated items. So places like moist environments like public change rooms and swimming pools are common places where this happens as well. And it is very likely to spread amongst family members as well. So usually if you've got one family member with a verrucae, you probably got, there is a risk factor for the rest of the family. And lastly, reduced immunity also contributes to the likelihood of this happening. The most common treatment is liquid nitrogen. So we would freeze it off through a podiatrist or GP could also do it. Salicylic acid, similar to corns and calluses, is also a common treatment. You can get this over the counter, which is about 40%. Any kind of tincture above that, so about 60%, will need to be actually recommended and made by a pharmacist and then done by a doctor or a podiatrist. They would apply it, put a donut pad around it just to cover it and then cover it. And then, to just really make sure the medicine gets in. Debridement of the lesion is also common. Basically, you would just actually, because they usually come with a callus as well, you want to really pare it back until it's actually started to bleed, because this will actually elicit an immune response from the body to let the body know there's actually wart here, so they can send antibodies to basically get rid of it. Lastly, I've put here the Gardasil vaccine. This was recommended by a podiatry surgeon back when I was in uni. So the Gardasil vaccine is the cervical cancer vaccine, and it's not the exact same virus, but it will trigger a general immune response. So the recommendation in the past was to say that if someone has chronic warts, to recommend that they go to their GP to get the Gardasil vaccine. Next up, we've got dry and cracked heels. This is also a very, very common concern I get from my clients. The technical name is anhydrosis, so an meaning lack, and hydrosis, a lack of water. And you do get what we call fissuring. So these kind of cracks in the skin, which once they open up are actually a portal for infection as well. Essentially, the fissuring happens because as you walk, because the skin around the heel is quite thin, as the heel compresses onto the floor and that fat and the skin continues to kind of expand, because the skin is not resilient enough, it causes it to split. As you can imagine, as you can see from that picture, it can be quite painful. And like I said, it can be a portal to infection as well. So the big cause is compromised skin integrity. Because of your feet, they actually rely a lot on sweat secretions to stay hydrated. As you get older and skin gets drier and it's not as resistant to these kinds of pressures, they will crack a lot easier. A lot of medical conditions and ailments, things like diabetes or thyroid issues or other nutritional deficiencies, can also contribute to it. And lastly, harsh soaps or a dry climate. So cracked heels are much more common in the warmer weather, partly because people tend not to wear socks or shoes as well. And that really contributes to, heels and skin being more dry in general. Treatment, the big one is to use heel balms. They are all based on of a thicker consistency to kind of really get in there. And they're a very common and very, very easy way to treat cracked heels. If sometimes cracked heels can form callus as well. So filing of the dry skin or the cracked skin through use of a Morse disc or even just with the emery board can help with that. And I would encourage the use of socks and shoes just to help really get that moisture to stick and stay in there. And this also helps with the heel balms when using them. Next up, we've got ingrown toenails. Ingrown toenail essentially is when as you can see from the picture, is when the corner or the side of the nail, it curls and digs into the surrounding skin. They are usually painful, but they're not always going to get infected, which is great news for a lot of my clients. But they are usually, when they do get infected, they are usually accompanied by this thing we call paronychia, which is an inflammation of the nail fold. And in terms of where they're the most common, they can happen to every nail, but generally they're most common on your big toes, or what we call the hallux nails. So what are the causes? Probably the biggest cause is improper nail cutting technique. So in the past, a lot of my clients who've kind of cut down the side of their nails, they've unknowingly left a little nail spike, and as that nail has grown out, it's actually gone into the skin. The next one is trauma to the nail. So if they've accidentally not kicked their nail or they've dropped something on it and their nail's bent, that can also cause an ingrown toenail. And lastly, if the shape of the nail is what we call a pincer type nail, where it kind of already curls in, like a crab's pincers, they kind of curl into the skin, this can predispose them to having an ingrown toenail as well. Treatment, if there is an infection present, it is best to treat the infection first, just because we do need to cut it out. And it will be quite painful if there is an infection there. So generally, I would say jump onto the antibiotics for a week or two until that infection and inflammation really comes down. And then we can kind of get under there with the Black's file to get out that little nail spike and then kind of trim it out and then file it and make sure it's looking good. If it is a chronic ingrown toenail, we can do what's called a nail avulsion. So either a partial nail avulsion, which just involves taking out the piece of the nail that is causing the ingrown toenail. This is done under local anesthetic. The nail's cut out and the nail bed is phenolized and burnt off so that it doesn't grow back. Total nail avulsion, which just involves the same thing but taking out the whole nail itself, is also an option. Next up, we have bunions. So the technical name is hallux abductor valgus. And it's not so much a bone, but it's actually the joint moving outwards, as we can see from this picture. And they're not always painful, which is interesting, I think, because I have had some clients who've, if you have a look at their feet, they've got really, really prominent bunions with zero pain, and they can walk fine and it doesn't bother them all. And then on the flip side, I've got clients who've got a very minor bunion and they can barely put their feet to the ground. Because the big toe is moving across and bumping into the second toe, it can cause other problems. Because as you can imagine, if your big toe is here and it's moving across, it's going to need space. So what tends to happen is then the second toe will claw, and that big toe will either go over or under, and that can cause hammer toes and other problems as well. In terms of causes, there is a genetic component to it as well. I do hear a lot of my clients say that, oh, I've got my mom's feet, or I've got my dad's feet, which usually means that they've got large feet, with bunions as well. It is more common in the female population because they tend to wear much narrower shoes with a narrow toe box, which compresses the digits at the end and can cause bunions. So improper footwear, tight-fitting shoes with a narrow toe box will contribute to these as well. So in terms of treatment, the first thing we want to ask ourselves is it correctable? So can we actually move the bunion out and make the toe straight again? Because if that is the case, then we do have a few options. We can use toe separators or little bunion sleeves just to kind of open up that toe a little bit, give a little bit more range of motion, and just if that assists with the client's pain and the way they walk, that's a great thing. We do want them to have proper fitting footwear, nice wide toe box, so their toes have room to splay. And this also opens up options with orthotics. In terms of orthotics, they won't stop the progression of a bunion, but they will really slow it down and just help support and give a great quality of life to the clients as well. Surgery is also always an option, but it's kind of the last option. So you can do silvers, which would be just to get rid of the bump itself. On the flip side, if it's not a really correctable deformity, if the bunion itself can't really move, they might actually just fuse the joint as well, and then give them, a footwear with a rocker sole just to help them kind of walk and propel as they, go about their day. Next up, we've got tinea and onychomycosis. Onychomycosis just is the fungal nails. And it's what I like to call the bane of every podiatrist's existence because it really is everywhere. And it's probably the biggest concern for a lot of my clients and very, very difficult to treat. Tinea is tinea pedis, which is fungal infection of the skin on the feet. As we can see from that bottom picture, it kind of presents as this patchy redness to the skin on the feet and also in between the toes, usually with itchiness, but not always. And as I said, with the fungal nail, it is an infection of the nail unit and it presents as this yellow, thick, brittle nail that we see in this first picture here. It is important in terms of differential diagnoses that psoriatic nails, which is basically caused by psoriasis, is also a factor. In 5 to 10% of cases, it presents without any history of psoriasis or any psoriatic lesions on the rest of the body. The other one we do want to watch out for, which I always say as a precaution, is melanoma. So basal cell carcinomas can actually happen in the toe and it will present as a kind of discoloration on the nail. So as a aside, I always make sure to mention this because I don't think it's something you ever want to miss, even though it is very unlikely. In terms of causes, trauma is a big one. If there's trauma to the nail and causes it to thicken. High-risk areas, so things like shared change rooms or garden is a big one. Or if you've got a family member who's already got fungal nails, then that's also going to be a risk factor as well. And lastly, as we've mentioned with a lot of these things, age is a big one because that leads to a weakened immune system. And if you've got tinea, and then that is also exposed to the nail bed, then they can actually spread from one to the other. So in terms of treatment, testing is actually quite ideal, even though clinically we can actually look at a nail and usually very easily guess whether or not it is actually fungal. We do want to actually test it. And the reason is because if we find out exactly what the fungus or the type of bacteria that's causing it, we can actually pinpoint our treatment in terms of the medication we use. So you would take a sample of the nail and you send it off for PCR and for testing for growth, and then you would go from there. This is done through the doctor. I think it costs about $70 to $80 if memory serves right. So topical and oral antifungals are a way to go. You can use both actually. Oral is better than topical, and generally, if they can take ibuprofen, they can take an oral antifungal as well. If you do use topical antifungals, I would recommend you really got to cut the nail short and try to get the medication right under the nail to penetrate the nail bed. And you will be using it for a minimum of 6 to 8 months for the topical. In terms of oral, you're probably using it anywhere between 2 to 6 months. Physical treatments are also very important. So burring and trimming of the nail physically, as someone put it to me once, you really want to get to that gooey fungal center to really get it out of there. If it's quite thick or quite inconvenient, or no medications have worked, removal of the entire nail is also an option as well, which is a total nail avulsion. The aim of treatment is for what we call clinical cure. So we want the nail to actually look normal again, but we also want it to be mycological. So we actually don't want there to be any traces of fungus left. So I thought I'd talk a little bit about in podiatry what barriers to foot care there are. The first one is what we call cultural. So perception of pain and importance of foot care. A lot of my clients, especially those who come from a culturally and linguistically diverse background, to them their foot care wasn't important because they came here to basically take care of their family for a new life. So they would just push through. There was also this perception that if you get pain in your feet, you just keep going because there are more important things to go. And this kind of carries with them now because they still think that, well, if I've got a little bit of pain, I've just got to kind of deal with it as long as I take care of the basic needs of the foot. So those would be things like make sure no corns or calluses, I've got a nice fitting pair of shoes, and I can get someone to cut my toenails. And I think at a basic level that this is okay, but part of my role is to try and educate my patients a little bit to say, well, actually, if you've got this pain, foot care is important because it actually affects your overall quality of life as well. The next one is a financial barrier. To them, it's not a priority, or it's an extra unnecessary cost. So that's why I think things like home care packages or the NDIS or the chronic disease management plans are a great thing because this actually helps to remove a barrier for some of my clients to actually get the foot care they need. And then it's a next conversation to say, well, okay, now if you need a little bit more help, well, maybe we can get you some footwear or some other bits and pieces, creams and moisturizers to help with that as well. And the last one is a social barrier because there are aesthetics considerations. I do have a number of clients who they paint their nails, not so much because they want to look nice, but because they actually want to cover up, toenails that they think look bad, thicker nails they might not even be fungal, but have just been growing thicker due to trauma or due to their previous occupation. So I think, it's very important, if one of the things is that my clients, they feel a lot better after getting their toenails cut because they have a little bit more confidence to wear things like open toe shoes, especially in the summer. And I think when we put all these three things together, even though part of the job is to actually care for their physical needs, cut their toenails, get rid of calluses, take care of their fungal infections, a big part of it is actually the rapport that I build with my clients to be able to say, well, you've got these barriers, here are some questions you might want to ask me, and I'm happy to try and answer them and kind of come alongside you to journey and just make sure that, yeah, you realize that it's quite important because it's going to help you overall in your quality of life to do the things you want to do, whether that be taking a walk every day with their dog or going gardening or just going out with friends and being able to wear open toe shoes and enjoy a cup of coffee. So what do I do specifically in my role as a podiatrist? So I've got regular appointments in here at Empower. We do 6 weekly appointments, and mainly this is to maintain their foot health and hygiene. So it's to cut their toenails because they can't, because either they've got hip problems or back problems, or it's just very inconvenient for them. And also looking after their hygiene, especially if they've got things like diabetes as well, making sure their feet are moisturized. If there are any kind of if I can see tinea or other concerns, I can bring it up with their manager or their doctor as well. Next up, we do have diabetes assessment. So I haven't talked about it too much today, but diabetes is actually one of the biggest things I see. And diabetes affects the feet in two ways. It affects the sensation and it also affects the blood flow. So I'm doing assessments for both these things to check if they are getting filling in their feet and are they getting enough blood to their feet, because we want to know that they're able to feel a rock in the shoe, they're able to have proper balance. And if that is the case, that they do get a cut or a wound, is it going to heal? And lastly, we do footwear assessments. So looking at their footwear, looking at the way they walk, and whether or not, ideally if they're, because a lot of my clients will be wearing very comfortable, easy to slip on and soft shoes. Is that the most appropriate? In most cases, probably not. But like I always say, I'd much rather than wear that than, go barefoot or wear kind of just socks as well. So with the footwear assessments, I do find that it's working with the client to say, well, we want you to be comfortable, but we also want you to be supported so that you don't have falls or you don't get pain or calluses and those kinds of things as well. So in summary, the feet are quite important. You're going to use them your whole life. They're going to do a lot of walking. They're going to take you through a lot of things. Age is a big risk factor for all the common foot concerns I see. It's not the only one, but because age affects a lot of the things with skin and general health and well-being, they are going to end up affecting the feet as well. And I think seeing a podiatrist is important not only as an ongoing measure, but also as a proactive measure. Some of my clients, their feet are actually very, very good for their age and for their level of activity. But to them, seeing a podiatrist is more about getting ahead of things like, well, am I at risk of getting calluses or corns? Am I wearing the right pair of shoes? Am I cutting my nails properly? Am I having all this right information and expertise to be able to live my life how I want to, and be pretty much pain-free. Okay, so that's the end of the podiatry part of the webinar. So a little bit about the clinical education sessions we provide at Empower. So next up, we do have our COPE dementia program, which is coming up on, the first one is on OT week, which is the 29th of October. There is a QR code there, which you can scan, or you can go to the website events pages to register and know more about what we do here at Empower. In terms of service coverage, it does differ between states. So please contact us about what services will be available in your area. Yeah, so if you do have any questions, I will hand it over to Carmody to try and answer them to the best of her ability. But if there are any questions that she can't answer, I will answer them in my own time. Thank you very much. This has been great, and I hope you learned a lot. And yeah, have a lovely day.
Hi everyone, my name's Carmody. I'm the Podiatry Manager here at Empower Healthcare. So opening up to the forum to everyone, if anyone's got any questions, do feel free to reach out. We'll sort of stick around for a couple of minutes there. You're welcome to type them in the chat if that's easier, or just unmute yourself and feel free to reach out. Yeah, Leanne, go ahead. You're just on mute, Leanne.
Sorry, I didn't mean to do that. Sorry.
That's okay. We've got some questions in the chat. I might just start with that. So we've got, do all podiatry services offer a diabetic foot assessment? Yes, we typically do. So as part of our initial podiatry assessment, we would review the general foot health of a client. And as part of that, if the client does have diabetes, we would make some recommendations as part of that. So whether it would be an annual assessment, usually that's fairly typical, or if we're finding that the results sort of suggest more frequent testing, we'll make that in our recommendations as well. So yes, it does include a diabetic foot assessment. And we would usually pass on the results of any assessments onto the client's GP, just so they're across it as well. Just looking at some other questions here. How do you handle clients who decline podiatry services, even when clinically indicated? So usually the first protocol would be to notify the case manager and or next of kin if they're around. Obviously, we want to be there to assist our clients as best as we can. Foot health is often a precursor to general health as well. So we do always want to make sure that their foot care needs are taken care of. So if we are getting some refusals or repeat sort of refusals from clients, we would try and work with the next of kin to get them to sort of be a bit more receptive to services. We try and sort of address what are the reasons for refusal. Is it pain? Is it not really understanding what the service is really about? So we would definitely try and work with the case manager, client, and next of kin. So there's another question here. If I wanted to refer a client who is in a home care package, how do you go about it? Do you need to have the case manager contact you, or can the client do so? So yes, Susanna, you could most definitely reach out to us. So your best bet would be to jump on our website, the Empower Healthcare website. If you just Google us, there's actually a very handy referral form link on our website as well. So if the client's already got a case manager in an active home care package, the case manager would fill out the referral form and you would go into our intake process. So we would then, our scheduling team would reach out to yourself to let you know how soon we could sort of be in touch with services for your client. If the client wanted to do so, they're welcome to do so as well. So once again, just going through our referral form on our website would be the quickest way to get in touch with us. Next question here. What is the best practice for relieving pressure between toes? So when you say pressure between toes, I guess the first thing I'd be looking at is footwear. So the first thing to do there is to assess the general footwear requirements for the client. So if you're finding that there's a lot of pressure between the toes, is it sort of inadequate depth within the shoe? Is it too narrow a toe box? So that'd be the first thing I'd be looking at. Other thing is, just looking at, well, what's the general foot type of the client? So if they've got things like clawed toes or hammer toes, those sorts of things, we could look at making or molding what we call an autoform device. So often a podiatrist is able to mold a little toe prop to sort of separate the toes if that's applicable. And we can make that on the day after assessment, obviously, once we've seen the client. So there's probably two more general methods of treatment, but really we would be able to customize the needs on a client by client basis there. Susanna's question is, do we do mobile services? Absolutely. That's actually what we focus on here at Empower. So we absolutely do provide mobile services. Once again, do jump on our website to look into all our suite of services. It's podiatry and a whole range of other allied health services as well. So do check us out on our website. Some good footwear options for patients with plantar fasciitis. Plantar fasciitis, also known as heel pain. It's definitely the bane of a lot of podiatrists. We see a lot of these cases. So any good footwear, I'd be looking at something that's quite well padded. So what we're wanting to do is to offload or really support the client's arch and their heels in an attempt to really deflect a lot of the pressures in that area. So you'd be looking at some of the key characteristics in footwear would be, like I said, good padding, good support, a firm heel to make sure that the client's stable in their shoes. And depending on the mobility of the client, you'd be looking at either a lace-up option or something that's sort of a Velcro strapping, depending on the client's needs there. Any other questions from anyone there? Just scrolling through the chat here. Once again, feel free to just raise your hand if it's easier to just speak up. If I missed any questions there at all, Nicole, that you can see?
No, it looks fine. Thank you.
Perfect. Okay. Well, if there's nothing else from anyone, we might wrap up there. Thank you everyone for jumping on. Apologies for those quite visual pictures there of some lovely fungal toenails. But please do reach out if there's any other questions or anything that Nicole or I could assist with. And I'll leave you guys to the rest of your day. Thank you.